sessions were shortened to 30 minutes to allow more facility professionals to attend. And so we will get started. My name is Sarah Eve Schaefer. I am with the ESRD National Coordinating Center. Today we are focused with this Learning in Action Network event, this LAN, on dialysis care in nursing homes. We have two excellent facility professionals. Very excited for today's session, so we'll get started. This is being recorded. The slides and the link to the presentation, which appears on YouTube, will be shared with networks, which then can be shared in their network service areas following the call. These calls sometimes get pretty big, and so we don't allow folks to unmute themselves, but we do like to use chat. We'll ask you a chat question here just in a moment to see if that's working. And then again, these materials will be posted to the NCC site and our YouTube site and shared with ESRD networks. So just a setting here, if this is your first time or if you haven't attended a LAN previously, we're really trying to take our learning into action. And so as you listen to today's presentations, when you walk away, share this with folks at your facility or colleagues or leadership. Commit to being present with us and applying one idea. And then please too, we do keep the chat open. And so please share your thoughts, your kudos, questions to our presenters via chat. And we'll try that now with our first question. So if in chat, you can make sure you click to everyone and answer the question, have you previously used the change packages to work on your clinical outcomes? So if you haven't used them or you're unaware, then thank you, Yolanda, Aisha, Jamie, for answering that. Looks like chat's working. For those of you who haven't used them, if you hold your phone up to that QR code right now, you will be taken to a link. I will share that again at the close of our presentation. Great. And as a reminder, we do update these every year, so they will be updated for 2023. And with that, we are going to move right into our presentations. And Lydia, you're up first. Lydia, you ready?
Yes, thank you. So I was asked to talk today on a program that we have started with DaVita. It is our SNF dialysis program, and essentially what our program is dialysis centers inside of nursing homes and rehab. We have 4 to 6 stations typically, and we treat very similar to in-center 3 days a week treatment. And the idea here is to decrease the need for transportation and increase their ability to make rehab appointments, make wound care appointments, spend more time in therapy, just giving more time and quality of life back to the patients where typically they were being transported out, having to sit in center and then be treated back. We work very closely with the SNFs. This allows us to have a better quality of care for our patients as far as working with the DON, the social worker and dietitians and other staff at each SNF facility. So that's kind of the general concept of our program and the reason why we have done it. It has helped to decrease some of our blood transfusions, infection rates. We're able to kind of keep a closer eye on things like blood loss, TI, bleeds. These are all areas that we've seen improvements in doing this program, along with just the improvement of their quality of time given back to the patient. So I have a question is, who is providing the dialysis? Is it the SNF or is it DaVita employees? It is the DaVita employees. So the employees on staff are nurse and a tech, and then we also have dietitian and social workers and biomeds who come and cover the clinics as well. You're welcome. Any other questions on what we do and why? I know they've asked me to talk for a while, but there's not too much. Peritoneal for us right now is not an option for our program specifically. It is strictly hemodialysis. We have looked at that as some options for in the future, but currently not now. We do treat pretty much the same as an in-center. That's something that's different than some other SNF programs. where a lot of them are using Next Stage. We use our typical 3 days a week treatments here. How many states? I think it's 30 plus we're in right now. It's across the U.S. I specifically cover Louisiana and Houston, Texas. A lot of questions at once. So do our social workers interact? Yes, they do. They talk to the social workers out here. As far as our quality of measures, I see that question. We go off the same as our in-center and home programs. It is the same quality of measures. For the most part, this is good because we do hit their metrics the same. We have seen some instances where this is a little harder on us because things like we still count for transplant, for example, the same, but none of our patients really always qualify for transplant, but you have to keep in mind that a lot of our patients are typically short-term stay. They're just here for rehab, so they still need to be followed up on for transplant as well, even if it is, for example, if they come in with a catheter, is another example, even though we may not be able to get a good access in because they're in here for an infection or whatnot, they still need to maintain that plan because the ultimate goal is to provide them the best quality of care to get them back out of rehab. So let me scan through some of y'all's questions. The social workers' responsibilities are the same as in center. They still have to do the depression, the monthly notes. We report out monthly to our medical directors and do our copies, and it's all the same as in center. How large does the SNP have to be? It really is not a certain size. It really kind of depends on who is around, who's the best fit, and who is wanting to put the center in and would benefit from having a dialysis center in their market. It's more of the dialysis population more than the size of the SNF. We dialyze up to 6 patients at one time. So typically, in theory, we treat up to 36 patients per SNF. Ratios for RN and PCTs. We run 1 RN and 1 PCT per shift. DaVita from acute programs. Yes, we are all one program, so we do cross-train. We encourage that within our company. So if there is a DaVita teammate that is with acute or chronic and would like to cross-train with us, that's an option. And we also do it the other way, where we've had teammates that work with us that like to work in center, and we'll let them cross-train as well. We are at specific SNFs. The SNFs, we have contracts with them. We're in them. We do not travel to different ones. Reducing catheter infection. For us, a lot of the dialysis units that are inside of SNFs are typically 5 days a week treatments using Next Stage, so they are actually being accessed, their catheters, twice as often as they are with us. So that has helped a lot. The other thing is really working with the SNF. So we've made a really large commitment to increase our communication with not only the DONs, but with the nursing staff. And so they allow us to meet in their daily and weekly huddles and provide education on catheter care, along with other things as well. But we do focus on the catheter infections with them. It's letting them know if it comes uncovered, how to clean it, to notify. The other thing is to notify us, because even if they're not in with us, we can still have a doctor around, or we can be in that we're in the same nursing facility as them. Blood transfusions, those are really work well because we're able to communicate with them if there are signs of blood loss, and then we monitor them as well, and it's a quick share with the nursing staff. and fistula placement. So we work very well with scheduling, not only for fistula placements, but any of their appointments. The idea of our program is to increase the amount of appointments that they can attend for their doctors without missing dialysis. That includes the fistulas, so we are able to work with our schedule at the SNF, and even if we need to move the patient around to kind of accommodate, that's something that we allow time for to make sure they meet all of these appointments. The other thing is that kind of in the nurse huddles that we do when we do education, for like catheter infections, we can also educate on filling for the fistula, for the thrills, educate them on not laying on the access, all these methods of prevention to make sure the fistulas do last longer. And if they're able to catch it versus waiting, if it happens on a Friday night, waiting for them before they get there to us on a Monday, that's something now that can be called on that Friday, and we have a larger chance of saving that fistula. The amount of nephrologists assigned, that is just per the nephrologist in the market. We encourage all nephrologists around, not just DaVita. The goal of our program is not a DaVita push. It is more for just to improve the quality of life for our patients. So if a patient does come to us that is from a competitor, we do make sure they discharge back to that nephrologist and that practice. We do not transport our patients. It's asking about if we have a hard time moving our patients. We do not move them. The SNF does. We are not able to go and get the patients because that would mean we would have to leave the patients treating on the floor in order to move them, and that would put our patients at risk that are in current treatment. If a patient is accepted for rehab, are they admitted as your patient, or are they considered transient? They are admitted. We admit all of our patients. Mistreatment rate, that is a very good question. If we do see a decrease, being that we can go and talk to and work with the social workers and the family very close, and here being at the SNF, do we have high mistreatment rates? Depending on the SNF, depending on the patients, yes. You also have to consider that a lot of our SNFs are not as large as your chronic clinics. So some of our SNFs may only have 15 patients. If you have one patient that's chronically missing, it's going to make your rate pretty high. Is that an issue? Yes, it does, because we do go off of the same quality metrics. So it does affect that. But ultimately, we are improving the amount of mistreatments overall. We are also able to improve the mistreatments on just the fact that if they do have a doctor's appointment or something, we are able to work with the SNF a lot better to reschedule them, whether it's to a different day or later in that day or earlier. We're able to work with the SNF a lot closer on those. Is this basically like a DaVita unit that is at the nursing home? Yes, it is exactly like that. Ultimately, we look very similar to any chronic dialysis center. If you were to walk in, you would feel right at home. It looks the same. Do we have all this list? Yes, we do. You can reach out to us and we can provide a list. I don't know what area you're in, Terry, but we can provide that list. And would be happy to. So you are welcome to email me or a local DaVita near you, and we can provide any of these lists, because I know there's quite a few on here, just to find out where they are, which ones are closer. Or I can provide it to Sarah, and she can provide it out. Are you doing patients that are less than 30 days? Yes, we do have to still admit them. They are less than 30 days. We do typically know that in advance and work to keep them a chair at their chronic clinic. AKI is tricky. We really depends on the insurance, and if it's covered, we absolutely run them all. technically we can treat all AKI patients. It's really up to the SNF partners if they want to pay the difference in the fee. Typically they do not. So AKI really just is dependent on the patient. I don't know if I'm going over time, y'all keep me on base here. Do we turn on CWL? Okay, I know I'm supposed to be talking. I'm just answering questions. I feel like that's the easiest way to talk about it, just give them what you want to know. Yes, we are on CWL. My email is lydia.broussard@davita.com. So my first name dot last name at davita.com. Yes, I'm sure, Sarah, y'all can send out my contact information if they need it. Oh, I do not know about Southern California. That is out of my territory, so I would be lying, but at some point we hope to be everywhere. I would say that rather it is DaVita or someone else, at some point in the future, SNF dialysis is going to be just like any other program within a nursing home. It's not going to be, do you have it? They're all going to have it at some point. Dialysis is just a growing field, and so is the nursing home population, and they just go hand in hand, and I do believe this program will continue to grow with DaVita and with other people. I feel like that might be the end of the questions.
Yeah, Lydia, let's just wrap up one more time about modalities. I think a few people asked. We know it's not peritoneal. Okay. Is it staff-assisted HHD, or is it just straight, for lack of a better term, in-center hemodialysis?
It is for lack of better terms, it's in-center hemodialysis, but it is technically considered, I would say staff assisted, but yes, it operates just like in-center. Great.
This is excellent. I appreciate everyone's questions. Lydia, you're a great sport answering them off the cuff here. We will share details from this. Lydia, be ready to have your inbox blown up. We will share the details following this with the ESRD networks. And we'll take a quick pause. There we go. Take a quick pause and we will move over to our next dialysis professional. He will now see just what might come his way. Brent, you ready?
Yeah, ready.
All right, it's all you.
So we are Bridge Dialysis. You can go next slide. I'll give a quick overview of who we are. So Bridge Dialysis, a little bit about my background and Bridge background. So have been in the nursing home industry for a couple of me and myself and my partners, 15 plus years. We are an affiliate new business venture program that was started with one of the largest nursing home providers in the nation, but we do act independently as Bridge Dialysis. Right now, so we've been running the program and really just focusing just on the SNF dialysis program, just with the needs and all the stuff and everything that Lydia touched on is absolutely a big need when it comes to the SNF setting and the value it brings to residents. So we've currently got 6 locations. We've got 2 more coming on. And then we've got additional states that we are entering in 2024 as part of our program. So that's a quick overview of Bridge. You can go next slide. Kind of the focus is, and this is the stuff as we go down the path as Bridge, our experience is we have a mixture of dialysis, but then we also have a mixture of longtime nursing home industry professionals. And we're trying to mesh the two to really create this symbiotic relationship that makes sense for the nursing homes. When I talked with Helen about speaking on this, I wanted to focus a little bit about things we're learning and the approach we're taking from how we ran 5-star skilled nursing facilities to really what we're trying to do as we set up a dialysis company to make it just as effective. Obviously, we know the goals and the network goals around reduced infections. We're becoming more understanding of the increase and the risk that comes with dialysis patients. And I think it's safe to say that all these risk factors are probably escalated when it comes to nursing home residents just because of obviously the complications in their acuity, the higher acuity care patients. These are not just your normal traditional patients, but when they're in a SNF, man, it brings a whole new level. One thing that we have found is super crucial as we open these programs is, and Lydia touched on this also, like the significance of the communication with the skilled nursing. When we're talking about access issues, when we're talking about infection rates, we went through some ICAR surveys with the state, and we found that, yes, we can limit all these things and do a lot better in our dens in the skilled nursing facilities. But the risk factors are still open because these residents live on site and are mixing and mingling with staff and other residents on the whole campus. And so the communication, the staff training, not just with the dialysis company, but also with the nursing home that you're partnered with is crucial. It can make or break the program. We found in one of the facilities that we partner with, we started to have a lot of access issues and fistula issues and failures of fistulas. And it came down to the fact that these patients were, yes, they're being treated great, and I feel like we're giving great dialysis care, but also when they're not getting dialysis, they're getting transferred, they're getting blood pressure cuffs put on fistulas or things like that, that if nursing home staff are not educated on the significance of this program, when they start to see the increase volume of dialysis patients, it can really do a negative effect on those patients also. Other areas around anemia management, blood transfusions, all those things, we have found that working with our medical director and the other nephrologist, we've been fortunate to be able to dial in and really use our QAPI process to build it out very robust and make sure that we're looking at patients individually, along with a big perspective of what we're doing as policy and procedure for our dialysis company. It takes a lot of ongoing assessment, a lot of adjustments. We are finding, and obviously this is the value. This is our big believer when it comes to the benefit of skilled nursing and dialysis mixing. Is a lot of these patients are sick, and if you can work in obviously extremely sick, and you can work in conjunction with the nursing home, it's easier to catch things and work through them with their clinical staff and our clinical staff, get them effective dialysis, but then also do all those things that we talk about, preventing readmissions, reducing infections, reducing the downtime of being out in transports and all that, and be able to provide a thing on site where we're working with the nursing home where, man, all these measures are in line, plus the patients are getting their therapies that they need to get better. They get the benefit of getting out their activities, the quality of life, and all those things that were already touched on with this. You can go next slide. The big thing that we have found a lot of value in, and this is just kind of a quick snapshot, we have made our QAPI program more robust than even what we saw on the skilled nursing side. As in a nursing home operator and running facilities, you find that QAPI can either make or break a facility. It can be the reason that a facility is stagnant, or it can be the reason that a facility becomes 5-star, hits those gold measures, all the things that CMS dictates when it comes to a heavy regulated industry of nursing home. And we're trying to implement that same process when it comes to our SNF dialysis program. These are just a few things that we go over, but we are consistent with it. We're doing monthly. We have our medical director. We're digging into the weeds. We're looking at every case. We're making adjustments to the programs. We're really just using this tool. And so our QAPI tool has really been the guiding star for us as we learn from the huge mistakes that maybe we started when we initially got in to where we come now, to where we feel like we're getting confidence and some legs behind what we're trying to do. You can go next slide. And sorry, then I'll jump over some of the questions. Helen asked them, what are the questions? There's some of the things that we learned. The importance of the involvement with the state entities, right? We learned a lot more from a nursing home side. You understand the regulatory and the heavy book that comes with CMS regulations, state regulations. As we've entered and got licensed in different states and different nursing homes, just realizing the different entities and resources within states that really do, as nursing home program becomes more of a thing, there's some states that obviously have heavier regulation around it, but then there's other states that just follow the CMS regulation. And from the industry itself, I do think you'll see more and more states have heavy regulation, just like they do on the nursing home side. We've got a long ways to go with the network engagement. I feel like we learn every time we hop on these calls, and we appreciate what we're learning from the network and the resources that are sent out. We're realizing there's a ton of resources, and honestly, if there's a problem, we're fortunate we have a mixture of some awesome longtime dialysis professionals, and we have some awesome long-term nursing home professionals on our side, and we're finding there's just a multitude of resources and ways to make it the best it can be. The right leadership structure. We've navigated this trying to understand it on the basis where it can be a longevity thing and a great thing with between DONs and ADONs and our nursing staff on the dialysis side, and making sure our structure aligns so that our social worker, our dietitians, all of our people can easily connect with the people on the nursing home side. And they can speak the same language, they can speak the same understanding, they can work through and understand and be empathetic of each other's processes. We also have a pretty robust compliance team that we've chosen to do more frequent compliance audits, and we provide these reports to the nursing home. We provide it to our partners that we work with, and we're doing this all on continual CMS regulations. So we're choosing to invest heavily in the compliance aspect of what we do. And then just again, the ICAR audits value the state affiliations, working with the organizations that have funds out there to come in and give the recommendations. We were in a facility that had some big infection outbreaks, nothing tied to dialysis. But unfortunately, our patients in dialysis were still living in this home. And so we went through these practices with the nursing home and with the state, and it just added a ton of value to what we learn and how we practice with our DENs and our setups in those nursing homes that we partner with. That's really the quick nuts and bolts. And again, I appreciate Lydia going before. There's a lot of great information that we would echo the same, that we feel and find value and love the focus that DaVita has on, love the focus that really it's about adding the value and quality of to these residents and to really improving the life and the outcome that they can have in their quality of life during this time. So let's see, when you're preparing to go into a nursing home, it's getting surveyed. I don't know if that quite, yeah. So it's similar survey. You have to have license, the survey process. Some states we're finding have similar survey teams that go in and do the surveys in the nursing homes, are also the same ones that do the survey for the dialysis. But it's all similar processes to get set up, getting a provider number, all that stuff that you go through on the regulatory side. We do some 5-day a week. There's a question, are you doing 5-day a week dialysis? So we do some 5-day a week for those patients that really can't tolerate. We have found that there are some patients along the path that, you'll see them cut off early in dialysis, that last hour, that last 45 minutes. Our medical directors, so we have tried some home hemo type care treatments. And we just try and be really flexible with the patients that need it versus and mix it with quality and benefit to the patient versus just making it a standard across the board. Obviously in dialysis, there's certain qualifiers or metrics that patients have to be able to qualify for the home concept of 5-day. And so we try and bring that same flexibility as these patients. Some are acute, some are here short term. And we try and make it flexible to what makes most sense for the patients. We also found there was issues with patients that did better on 5-day, but then they would convert back to 3-day when they went back out to the community, just from access standpoint. And so there's a lot of factors that go into deciding what's best for a resident. So, and I think next slide, I don't know if I had anything else that was really going to point out, just any other additional questions that weren't answered prior.
Well, thank you, Brent. We'll
Yeah.
pause here for a moment to see if anybody else does have some questions. People haven't been shy so far. Okay, seeing a lull in the questions, I want to just extend our huge thank yous. What states are you looking to spread to?
So we're working on licensing Texas, Arizona. I know there's questions around California. Just the state regulatory aspect to get into California was very different. So we're more focused on the West Coast at the meantime. Washington, we're in discussions with. So there are multiple states that will enter in 2024. We've just used Utah kind of as our pilot program to make sure we understand and can get into this the correct way.
Excellent. I am going to look to close today. Again, we appreciate both of you coming today. Lydia, Brent, this was excellent. It looks like some more connections there, Barbara, after the call. Excellent there too. So just a final plug here. There again is a QR code for the NCC change packages. They are across the OKR topics, and also including health equity. We revise these every year. So if you're not already working with these, they're a great playbook and a place to start. Data-proven interventions from top performers from around the country. And then just one last ask, when you close this window, or when I close the event today, you will be turned over to a short survey. If you please would just take that survey, even if you just answer the first question, which is, do you prefer the condensed 60-minute, the condensed 30-minute, or the longer 60-minute format? We are trying to make sure that we prepare these calls to work best for all of you. So find us and follow us on social media, ESRD NCC. Thank you so much. We will be sending out the slides and contact information to the ESRD networks in the next couple of business days, and they will distribute within their service areas. Thank you so much. Take good care.